so thrilled to have Dr. Allison Arwady as our keynote speaker. She is, as you know, the commissioner of the Chicago Department of Public Health, charged with leading the nation's third largest city's health department. And she's been at CDPH since 2015, when she joined as a chief medical officer and then became the commissioner in 2020. Good timing, Dr. Arwady. Prior to CDPH, she worked for the Centers for Disease Control and was an EIS service officer. And at the CDC, she worked on HIV, tuberculosis in Botswana, and worked on international outbreak responses in Saudi Arabia, working on MERS and Ebola in Liberia, probably very good training prior to COVID-19. And while based in the Illinois Department of Public Health, she responded to disease outbreaks across the state. She's very well educated, coming from Harvard, Columbia, and Yale. And she's a board-certified internist and pediatrician and still sees patients. So Dr. Arwady, welcome to CDRP.
All right, thank you so much for having me. I don't always actually have the opportunity to take a whole morning and sit and think a little bit, but I cleared my morning because this topic is the topic for me. Many of you, probably if you've been here in Chicago, you now recognize me. Can I tell you how much my goal in life was not to be recognized on the L as the COVID lady or the CDC doctor or, Dr. Ezike or whatever it is. But regularly 5 to 10 times a day when I am out just walking around Chicago living my life, people stop me and talk about COVID and have strong opinions, most of them positive, but it's been a very interesting and unexpected turn to be leading the health department during the pandemic of a century. And when I think about communication and lessons learned, I could talk for hours. But I decided to show you a little bit of how I've changed the way that I think about communication by, in part, not bringing a set of slides today. Because so much of what I have had to do and the Chicago Department of Public Health has had to do is not pre-develop messaging. It's been needing to be very, very nimble, to be responsive to whatever the conversation of the day is. I really appreciated the presentations from all of my colleagues before, and I'll make some references back to them. I have worked a lot on outbreaks. This is what I am trained in. And no matter the size of the outbreak, from a small, foodborne outbreak to a global pandemic, I always, when I teach about outbreaks, I teach about the 4 C's. Where do outbreaks go wrong? People always think they go wrong on the first 2 C's. The first one is cases. The traditional work of the healthcare system. What do we do with the people who are sick with X disease, and how do we keep the healthcare workers safe? How do we build that? We actually usually know what to do about people who are sick. We know how to protect healthcare workers. Doesn't mean it's not a lot of work to get it done, and we saw in COVID how threatened healthcare systems can be. But the C of cases is always what people imagine goes wrong. It's never where it goes wrong. The second C is the bread and butter of public health, containment. So whether that is the vaccination work, the contact tracing work, the work that goes along with what the healthcare system does, but is traditionally outside of the walls of healthcare, we, again, for most diseases, we know what to do. We know how to execute on it. It takes resources. There are challenges. We were talking, Dr. Pollack was talking a little bit about early on some of this debate about wearing masks. Yes, some of that was around, did we have PPE available for healthcare workers? But I'll be honest with you, a lot of it was because we didn't yet know that you could spread COVID before you had symptoms. And when it became more clear, different than most other infectious diseases, very different than Ebola, which was our most recent focus here, the fact that you could be walking around very contagious and spreading symptoms for 2 whole days before you got sick, before your test turned positive, that was actually the seismic shift in terms of saying we need everybody to put on masks. So there's a lot of pieces of this, but there's cases in containment. Tons to learn. You never get it all right, but we know what to do more or less. And as we learn more about a disease, you incorporate it. What do you think the 2 C's are where outbreaks go wrong? Communication is one of them, and coordination is the other. Doesn't matter the size of an outbreak. You have to put as much or more work into thinking about how we are coordinated across all levels of government, across all healthcare providers, across different community-based organizations, standing up things like a citywide vaccine operations center that is all about meeting a city's need for coordination, and then communication. And let me tell you that we don't historically fund public health communication very well. The Chicago Department of Public Health is very typical in that most of our funding comes directly from the federal government. Most of it comes directly from the CDC, but it all comes tied to specific diseases. So you get this much money to work on tuberculosis, and this much money to work on opioid overdose, and this much money to work on COVID. What we often need, though, are not the disease-specific funds. We need to really develop our ability to communicate better across the spectrum. And so I will tell you some of the best things that have happened at the Chicago Department of Public Health over these last few years. I sometimes say my favorite investment, the best thing we've done, sure, we've done wastewater. Sure, we've built the ability to do variants. Sure, we've done amazing community engagement. The best, most useful source thing that we've done with funding, we now have a graphic designer. What a concept, right? We have people who are trained to work on social media, who work all the time on Facebook, who who tweet for me on Twitter, who whatever those pieces are. We never before had the funding to do some of that more specific work, which meant that we were slow. And I think when I think about where very often public health has not done well across this country, it's because we were set up to be not quick enough. And very often here in Chicago, we needed, and we often were, a little bit out in front of what the CDC might be saying or what was completely approved, because misinformation and disinformation goes much faster than the real information. And that means that by definition, we will make some mistakes. I can tell you that before COVID, the health department, I would go out and I would do press, once a month. We would have a press conference a few times a year. We would draft in a lot of detail what those remarks are. They would get vetted with the mayor's office. We would practice. You would plan weeks to months around a press event. And then you would do that press event, and that was kind of it, right? There wasn't a lot necessarily of maintaining that story. Well, when COVID hit, and yes, I was confirmed as commissioner 4 days before we activated for COVID, and we had our first case here in the Chicago area in the late January, actually, of 2020. The second case in the U.S., the first case of human-to-human transmission. And for a few days there, I was writing out what was I going to say every time I stood up and talked. We were trying to be more regular around that. That fell apart within about a week. And instead, we needed to stick to core messages, but we had to move away from that traditional method of communication. So when I was an EIS officer, which if those of you don't know, it's a 2-year basically postdoc training through the CDC to work on outbreaks. That's an amazing job that I had. We had a little bit of training on communications. The top line thing was make sure you have a SOCO, a single overriding communications objective, right? That's how CDC talks. But the basics of what is your single message, and then saying it over and over and over and over and over again. I used to think you had to say a new thing every time you got up in front of the media, every time you talked with a new community group. Turns out it is more effective often to say the same thing 7, 8, or 9 weeks in a row with slight variations around what are you seeing locally. But that made me think differently about how do you simplify, how do you have the very top line messaging, and then tie it very specifically to local data. One other thing that we did early on was really embrace social media, for better or for worse. I will tell you that this is not something we had done a whole lot of as a health department, but very early on, you remember how scary this was for everybody in Chicago, how many questions people had. I knew, CDPH knew, we certainly didn't have all the answers, but we have, I've spent my career thinking about infectious diseases and outbreaks and what can we do. And so we started really early, in March as things were kicking off, doing these Facebook Lives. And I don't know if folks in the room are aware of them, but we did these 7 days a week for months. And what they were bring up the Chicago's local COVID dashboard as we developed that. Talk about what are we seeing in Chicago? What neighborhoods is it hitting? What race, ethnicity? Once vaccine became a thing, where are we seeing vaccine? Very grounded in local data. We would share out the messaging that was the messaging of the week, and then we would spend at least half or 2/3 of that time directly taking questions from the public. That is not a normal thing for a governmental agency to do. I will just tell you that. Normally, we tend to be much more careful, I think, and a little more scripted. Previously to COVID, you would imagine what questions people might ask, and you would work to answer them. But I will tell you, one major thing that I learned is that people will never ask the questions you think they're going to ask. It doesn't matter how much research you've gone out and done. And taking real questions from Chicagoans and being as transparent as possible about what we know, what we don't know, what does it look like in Chicago. This means, we went from 7 days a week to eventually 5 days a week to eventually 3 times a week. We're still doing it once a week. And it's become a way to bring in other things that the health department does that isn't COVID. But it's amazing to me how still, years into this pandemic, people ask good questions, and we've had to create the ability to try to be more responsive. So when I think about these lessons learned, and especially when I'm talking to academics at the University of Chicago, we have been so grateful to the many folks in this room and to your teams who, I see Jonathan Ozick, who helped us really think about modeling, and not just in a theoretical way, use that modeling we used it with the mayor to design a lot of the initial decision making that we were making here in Chicago. Certainly urban labs, working with evaluation of various things that we've worked on, people who have helped with behavioral messaging and really guiding there. But we need more of this. You all think a lot about things that we often don't have as much expertise or, frankly, time to think about. So I love the work that is happening here with looking at the Medicaid and Medicare, or looking at what's happening with the economics of this. We, in public health, very often are needing to move so quickly that we can't set up the evaluation structures that we need and that we ask sort of academics to look at with us. Because we're moving so quickly and because it's often not business as usual. So I would love, just in terms of a first thing, where you have students, where you have folks who are wanting to think about how does communication go better, not go as well, how do programs go better, not go as well. We would love to have you be at CDPH, be looking at our activities. I am all about transparency, so I know not everything that we have done has been good or right or gone well, but a lot of it has, and we've done a lot of fairly innovative things during COVID, but we've had very little opportunity to actually write them up and get them into the scientific literature. You saw, even in the height of COVID, we took a brief moment to at least get something in about our data related to school reopening, because that was such a political fight here. But most of what we've done, we've never actually told the story of, and we've never had formal evaluations. And I would encourage people in this room to help us look at that, because that's how we get better at messaging. That's how we see what is there. I think another piece I want to pick up related to messaging, which we knew, but what really came to light was some of what Dr. Tan was talking about with who is the messenger, right? It's not just about what is the message, but who is the messenger. I know I am not the best messenger, for many people in Chicago. I'm a white woman. I'm highly educated. I'm from the government. I'm a doctor. Like, there's a lot of things that people, by definition, are not likely to trust me. And so we, from very early on, thought a whole lot about how do we create these core message maps, but then encourage our partners to adapt those for that community, but also to hire people. So the health department had long wanted to fund community health workers, especially around chronic disease. There's excellent evidence that this works well. And when COVID hit, suddenly there was money. But was there money for community health workers? No. There was money for contact tracing. The very first real funding that CDPH got during COVID was more than $50 million to support contact tracing. There was a lot of pressure to get that turned around very fast. Most other states and cities hired a call center, or sometimes worked with a university. We said, this is an opportunity to bring our ideas around community health workers to life, but we'll do it with contact tracing. So the biggest grant the health department had ever done, more than $50 million. We have to do it competitively. The Chicago Cook Workforce Partnership became the lead. If you don't know, that's the organization that works to connect people who have had barriers to employment, whether it's incarceration, long times out of school, et cetera. Get those folks connected. And we made a decision. Our contact tracing core was going to be hired through South and West Side community-based organizations, many of whom may not have ever seen themselves as a healthcare organization. They were working on housing. They were working on job development. They were working on food security. But we placed cohorts of 10 contact tracers and a supervisor, 20 contact tracers and 2 supervisors. We did this as a earn as you learn. We had no educational requirement. We had folks who did not have a high school degree. They just had to be really good at talking to people, really connected to communities. Then they had to be able to get through the city college funded training that we paid folks to do. This eventually, it started as contact tracing. When vaccine money came, it morphed into the vaccine ambassadors. And then when additional funding came for health literacy, it's morphed into what we now call our community response corps. And the goal is, as other disease-specific funding comes in, use it to help support some of the chronic disease health worker type work. But we've hired more than 800 Chicagoans into this workforce. 94% of them are Black or Latinx, 63% are Black. Most had never been in a healthcare type setting. And these were the folks who not only were doing the contact tracing, but were doing the door knocking, were out at the neighborhood events, and then importantly staffed our call center. I really appreciated the graphic about how confidence overlaps with convenience, overlaps with complacency that we heard from Dr. Tiro, where people are making decisions about vaccine. This core of individuals, they staff our call center. We tried initially to just get messaging out through community-based organizations. We did have some of these larger vaccine centers, but all along our goal was to say, let's try to get this more into community. And so these folks still today staff our call center, 312-746-4835, which, because of feedback from community, we stood up here something called Protect Chicago at Home. Even today, in the city of Chicago, CDPH will bring you a vaccine free of charge to you and everybody in your family, in your neighborhood. We'll do that on weekends. We'll do that on mornings. We'll do that on evenings. We'll bring you boosters, first dose, second doses. That's kind of expensive, frankly, but it helped us get past all of the barriers. And we saw Black Chicagoans most likely to take advantage of that, just recognizing all of the other barriers and where we don't have as much healthcare access. We also really have worked to try to think about being as transparent with data as we can. You'll never see me up talking at a press conference or sharing, this idea of hyper-local data and then getting out of the way, funding organizations, funding trusted messengers. We stopped saying we're going to set up a vaccine clinic in, this community here, and started saying we're going to set up a vaccine clinic. Where would you like it? What does the outreach look like? A lot of work with faith organizations. I feel like we've had a lot of lessons learned around who is the messenger. We saw that actually with monkeypox that emerged, for which we had $0. How do we take some of those trusted messengers and expand it out? But thinking about, and I'd love to see some more evaluation actually of that. There have been very different approaches of who is the messenger. We heard some really nice work about community health workers, but there are more spaces here, and I think some real lessons that I would like to learn, as the health commissioner, about what works well and what doesn't. I also think we've had lessons learned to the point about how much do you take on the misinformation and the disinformation. This is not something that I had training in or that we had thought a whole lot about. We certainly have long had, I'm a pediatrician, right? So I've done a lot of individual motivational interviewing and dealt with vaccine hesitancy on a primary care level. But when you are thinking about these very different and political, often, ways in which decisions around vaccination have become part of your political identity, that was not something that I had anticipated or necessarily thought about. And we've worked to, for example, if you look back and see which TV channel I have been on the most for COVID, by a mile, it is Fox. Now, it is Fox Chicago, which is not the same as sort of Fox nationally, but it's about, we have prioritized getting, hiring folks at the health department, who are native Spanish speakers, who are then out doing a lot of the very hyper-local media, making sure that we have people who look like Chicago carrying this message, really prioritizing the WVON, one of the big, historic Black-led radio stations here. They're co-sponsoring with us our event this weekend at Kennedy King, and they've been really working to get that information out there. But who is the messenger? How do you simplify that? How do you get that out? We'd like to evaluate some more of that. And then, as an EIS officer, I was trained that your goal in an outbreak is to minimize morbidity and mortality, right? That's sort of the basic top line of what you are trying to do. But one thing that we've done more explicitly than we ever had during COVID was to say, of course our goal is to minimize morbidity and mortality, but also our stated goal right along with that is to build and maintain trust in the Chicago Department of Public Health. That is never something that I had thought about that explicitly, but we have seen on Facebook, for example, regularly we get, quote-unquote trolls. And the question is, do you engage with those folks directly? And we've changed our approach on that at different times. But I didn't know. There wasn't great research about how exactly should you do this. I want to point you to, if you don't know, there's a website called publichealthcollaborative.org. This was only born in 2020, and it was the CDC Foundation, the DeBowman Foundation, the Kresge Foundation, others got together because all of us on the ground were saying we can't keep up with the misinformation and the disinformation and needing some very real-time training into when do you acknowledge it. I already knew the things around sandwiching, right? You start with the truth, you address the misinformation, you finish with the truth, you do the values-based approach where, like on Facebook, when someone is very directly accusing me of getting rich when somebody gets vaccinated, starting with I can understand why you might think that, or here's this study that might have suggested, but let me sort of help you set that straight, trying to kind of keep this empathetic view. But this is not something that we've thought a whole lot about. But the anti-vaccine movement had done a lot of pre-thinking about this and worked really quickly to grow and sort of pull in interesting ways these political forces. And so the website that I mentioned, I found it extremely helpful because what they do is they track the misinformation and disinformation that is online at any given point, and it's designed for public health professionals, and it links them all. It tells you if they're red, yellow, or green. Red means we're really worried about this one. It's circulating a lot. For example, there's a red one right now. There was a small study of 11 people that came out that suggested that you could find traces of mRNA vaccine in breast milk for 2 days. That is not dangerous, that is not a problem, but it has been used and it's been circulating, and so that one is considered red. They give you very specific, here is what the facts are, here is how we suggest you address that. They'll label things as yellow. Yellow is, this is circulating, we're watching it, be aware, but we don't recommend that you address it head on. So for example, there's one right now that's circulating. President Biden was encouraging people to get vaccinated ahead of the hurricane season months ago, and it is now circulating saying President Biden says vaccines prevent hurricanes. Which sounds sort of crazy, except that it's being shared. And it actually, right, it's this sense of like, how do you build trust? And in this case, they say, we do not recommend at this time directly addressing this, but be aware of it. That's what might be coming to you, because we get people from around the country, by the way, coming still and engaging in negative ways because we're out still live on Facebook. And then there are green that are just not getting a lot of traction yet on Facebook, but they are misinformation or disinformation. Here's awareness, here's what you could do. And that very practical, real time of the folks who are out there monitoring social media and then giving us actions, that is wonderful, right? Where you think about how the work that you're doing to improve communication, how do you make it like immediately usable, because I'll look at that website and 30 minutes later, is when I'm up having to talk to folks. So when we think about building trust overall, I do want to just mention, on the point of politics, I feel very lucky to have been in this job in Chicago. But I also want you to know that even in Chicago, I had to have a 24/7 police car outside my house for some time there. I've had 5 different flavors of protesters at my house. I've had scary things happen. And I have seen, there are more than 300, I think it's over 350 now, leaders in my position at local and state health departments across this country who have left their jobs. In some cases because they've had death threats and they've had things spray painted on their house, really scary. And I talk to these people, right? There's a community of practice. And I want to highlight something that I took for granted, honestly, but I think is so important. There was a comment from one of the early speakers who said, I wish that the government wouldn't fight among themselves so much. And I will tell you that we also had a pretty stated goal that even if we were having some debate behind the scenes with the Illinois Department of Public Health or the Cook County Department of Public, whatever it is, we had a goal to have that not be the story. And I am worried that as this has been so politicized, and it's not gone that well in the U.S., there's a real tendency to sort of want to scapegoat public health at different levels. So you will never hear me speak critically about the CDC, even if there are things that I may not have agreed with how they've done it, and maybe there are things we can do better. Fundamentally, we are all on the same team as governmental public health, and I do think that's such an important piece to figure out how do you talk transparently about that, about what you can do better, but not further erode trust in the government. Like, it's great if people trust the Chicago Department of Public Health, but if they also don't think the CDC or the national leaders are telling the truth, like, we haven't actually solved that problem. But here, different than in so many states and cities around this country, our political leaders, for better or for worse, co-owned the COVID response. All over this country, we saw mayors and governors want to stand up and own the happy part. We're reopening. We can take the masks off. COVID is over. Great. Mayor Lightfoot here, and really for the most part, Governor Pritzker, stood right with public health during the hard parts. Often, we saw political leaders point to public health, point to the health commissioner or the lead at the national, state level and say, it's their fault that we're shutting down. It's their fault that the masks have to go on. It's their fault that we're putting a vaccine requirement in place. I don't want to do it, but they're making us do it. That division doesn't get talked about a lot. But when I think about building trust, we are part of government, sort of like it or not. And the ability for here, knowing that the mayor was really co-owning the hard parts and the happy parts, deflected a lot of the really negative, it's part of why I'm still in my job, frankly, even with that. And thinking about how all of us, governmental public health is critical. It is poorly understood. People don't understand the difference between public health and healthcare. And communication is so much at the core of what we do. So just to sum up, this is a chronic disease-focused group. We've obviously mostly talked about COVID and communications messaging. But as a health department, we are very interested in taking the lessons from COVID, from communications in COVID, into chronic disease. Some of you know the health department is focused on the racial life expectancy gap in the city of Chicago. From the 1880s all the way till 2019, we saw rising life expectancy, except for 1918 when the flu pandemic was. We saw it rise year after year after year. You only had a life expectancy of 39 years across the U.S. in 1880. It was up to 79 years by 2019. And then COVID hit. And we started talking really differently about essential workers, about crowded housing, about access to healthcare, about the very real facts that obesity and smoking and diabetes, these also underlie a lot of the disparities that we have seen in COVID outcomes. Vaccine is a critical part of it, but it is not all of it, and especially if you look at 2020 before the vaccine was available. So we saw in 2020, instead of a continued rise, across the whole U.S., we saw more, and here in Chicago, more than a 2-year drop in life expectancy. But we saw in Black Chicago, for the first time, average life expectancy fall below 70 years, first time in decades. We saw the biggest drop in Latinx life expectancy, more than 3 years of life expectancy drop just in that 1 year. When vaccine comes in 2021, we see some of that start to reverse and get better, but definitely not all of it. And when we are taking the big view as a health department, as people interested in chronic disease in the health of this city, we focus on the 5 major drivers of that racial life expectancy gap. Where today in Chicago, Black Chicagoans, no matter where you live, on average live 10 years less long than other Chicagoans. Not acceptable. Long history of structural racism, long history of mistrust, long history of disinvestment, but it is a fact. More than half of that gap is due to chronic diseases, due to differing outcomes on heart disease and cancer and smoking-related illnesses. The other 4 things rounding that out, number 2 is now COVID. COVID is still the second leading cause of death after heart disease. We'll see where it ends this year, but for the last 2 years it has been. Number 3, still infant mortality, which is all about what systems we create as a society. Number 4, gun-related homicide. Number 5, opioid overdose. These are the 5 things that drive the gap, to be clear, not just the biggest causes of death. But when we think about these huge problems in our city and across the country, we've got to work on some more strategies around communication. We've learned a whole lot. We've learned how to be quicker. We've learned how to, I think, be much more transparent and real-time with data, with messaging. We're still learning about how to combat and when to combat misinformation and disinformation and how best to do that. I will tell you, I don't think we have a lot of the answers there still. We have clearly learned the messenger matters, and more than that, building trust means investing in organizations and individuals that already have trust in community, and then using that network to carry those messages forward. So we've created something called the Healthy Chicago Equity Zones. I know some of you are already aware and involved. The whole city is in an HCEZ. We're funding lead organizations in every zone. In turn, they are funding community-based organizations, many of which would not have thought of themselves as public health. They worked on vaccine for a year and a half, but now we as the health department are not saying you need to work on this issue. We're saying you decide as a region. If you want to focus on food insecurity, or you want to work on healthcare access, or you want to work on violence, we don't care. It's about creating the structures, the trust, and the ability to have a workforce that is from community, trusting of public health, able to work on these problems all the time, who can then pivot in the time of an emergency or an outbreak or the next COVID or whatever it is. That is never work that has been funded appropriately in this country. And until we stop funding around diseases, until we stop funding only months after an outbreak occurs with short-term emergency funding, like we've seen with COVID, like we've seen with Zika, like we've seen with Ebola, like we've seen with H1N1, until we instead start thinking about preparedness, not just in terms of the stuff. We had millions of pristine N95 masks, thank God. We had ventilators. Did we have everything? No, but we were one of the most prepared cities, honest to God, in the entire country on the stuff of preparedness. We had amazing plans. The year before COVID broke, we had done a whole, we had gotten Chicago Public Schools together and said, what if there's a big pandemic? How are we going to feed the kids? How are we going to work on this? We had amazing plans that all came true. We had set up our mobile morgues the year before. We had done a lot of the traditional preparedness. What we had not done was build those structures of community trust and communication. We have now made big progress in building those, but I'm worried we won't necessarily be able to sustain them. So I want to thank all of you in this room. If you're here, that means you were working on COVID these last few years, I would say, in one way or another. This country would not be where we are, low COVID level, worried heading into the winter for sure. Fewer than a quarter of Chicagoans, even in their 70s and 80s, have had that COVID booster this fall. There's a long way to go. But I do think, at least here in Chicago, we've come some important way in terms of learning better how to do communication in a crisis. And I want to sustain that work. And I would ask all of you who are interested in this to think about helping us with that. We would love to see more research in exactly the kinds of things that we were seeing, the posters that are going to be upstairs. We would love you to think about directly working with CDPH, because we're just out here trying to solve things every day, often without a lot of time to do the planning, set up the evaluation structure that you would need. And so many of the lessons that we've learned, for good or for bad, are like in my head and in my team's memory. And we would really appreciate your interest and support, especially if you're interested in chronic diseases. We've got to tell the story of how we've built things in public health during COVID that need to be sustained in a non-disease specific way to work on what is half of the racial life expectancy gap in Chicago. Thanks.